Thank you very much, Honorable Chairpersons, for your kind introduction. And today, we've been all invited here in this beautiful city of Jaipur. And I will start my presentation by presenting to you the Jal Mahal, which is actually a very interesting piece of architecture, which is right in the middle of a lake. And I think you should all go and see it once. So before I begin, there's another architectural piece over here, which is called as the Hawa Mahal, which is a total marvel out of how it was designed several years back and how it has ensured that it's called Hawa Mahal because of the amount of air that it generates with the architecture. So without wasting more time, today I will be talking to you about infections, and my topic is the post-transplant immunoprophylaxis and vaccination and how you would prevent infections. It's a very pertinent topic because we have to know what are early and late infections and what is the kind of prophylaxis that we should be having in our country, because we are a country in which we have a lot of tropical infections, we have a lot of infections which come into immunocompromised patients, and obviously the most important is how to vaccinate and how to prevent these infections. And we know that India as a country is one of the leading centers for kidney transplantation all over the world, and infection remains as the cause of complication after your transplantation. So immunosuppression, as we all understand very clearly, that is a major predisposing factor for the developing of these infections, and they will be influenced both by the kind of population that you're dealing with and the strata of society that you're transplanting. Over the time that we have seen transplantation in our country, we have seen that these infections have grown because of the immunosuppression. We have better immunosuppression, more potent immunosuppression, and so we have to find out strategies in which we can protect our patients. So coming to the slide of what is early, what is late post-transplant infection, because if you don't understand what is the concept of early post-transplant infection, you would not know what are the kind of drugs, what are the organisms that you're dealing with. So in the early post-transplantation infections, it generally is in the first 30 days post-transplant, and these are all nosocomial infections. These are the ones that...
Sorry, sir, just for a pause. We would like to call upon our two chairpersons for this session, who is already there in the audience. Dr. Anil Kumar, sir, and Dr. Mohammad Faz.
Yes, so the early, welcome chairpersons. Yeah.
So you can resume.
Yes, thank you very much. Yeah, so in the early post-transplant period, which is in the first 30 days, you have the nosocomial infections, which we all understand are going to be hospital-acquired. They're going to be mostly MRSAs or ESBLs, depending on what you have in your setup. Surgical site infections. UTIs are obviously the most important because of prolonged catheters, which are placed sometimes in centers beyond 5 days post-transplantation. Apart from that, catheter-related bloodstream infections from catheters which have a long vintage before the period of transplantation, and pneumonias can develop in our patients, especially viral pneumonias, bacterial pneumonias. You can also have donor-derived infections, which are basically infections which are viral infections, such as HCV, and you can have mycosis. These are endemic mycosis in areas where these patients are already predisposed to getting exposed to mycotic infections and getting transplanted under immunosuppression, and the recipient-derived infections, which are influenza, pseudomonas, and aspergillus. Now, as you move from the first 30 days, you have the next period, which protracts up to the next couple of months, which makes it to about 365 days. And when you can have infections even despite having prophylaxis given to these patients, such as Mycobacterium tuberculosis, which is very rampant in our country, Cryptococcus, which is not very common, Strongyloides, which we see in patients who come from the rural belt, Leishmania from particular parts of the country, and polyoma virus, as well as reactivation of the old HCV, which has not been detected pre-transplant. And after your prophylaxis stops, which some centers stop after about a year, you can have resurgence of pneumocystis carinii and community-acquired infections such as UTI, pneumonias, and with a lot of antibiotics, Clostridium difficile, or even with water transport. And then beyond 365 days also, your patients are susceptible to infections, especially with opportunistic infections such as the CMV and EBV And if you have an EBV, then you can also have transformation into PTLD. The patients can also come to you with nocardia. And other community-acquired infections, again, UTI and pneumonias consistently remain the most important cause of infections in your patients right from day one till the end of point where your immunosuppression is to the lowest point and a patient achieved so-called immune tolerance. So in tropical countries, the incidence of post-transplant infection ranges from 50 to 70%, and it demonstrates a very distinct pattern compared to areas which are more developed. UTI, as we already have discussed before, is the most common post-transplant infection and can affect up to 80% of your transplant patients, and it can occur mostly in the first 6 months. And the microorganisms have we already spoken about, but important to know that in UTI, the commonest organisms appear to be E. coli, Klebsiella, and Proteus across different spectrum of patients in different strata of society as well as different countries. The prevalence of viral infections among renal transplant patients in our country ranges from 30 to 40%, with the reported infections such as CMV, BK virus, hepatitis B, HCV, papilloma virus, HIV, herpes zoster, as well as parvovirus. So there's an Indian study which says that the fungal infection, that is systemic fungal infections, which obviously are very, very difficult to treat in our patients, is about 6.1%. And you can see over here from the slide that has a very high mortality rate up to 60%. So what is the prophylaxis that you can give to your patients? So the most important and the commonest infection that you see, which is the bacterial infection, deserves prophylaxis. And so the drugs that provide effective protection against these should be used in your patient, and the simplest drug that we can think of is a single strength tablet of cotrimoxazole sulfamethoxazole combination. Why? Because this protects you not just against the urinary tract infections, but also against PCP and to some extent nocardia. So it's recommended for at least 6 to 12 months post-transplantation, and the period of highest risk of PCP is during this time. If you stop the prophylaxis, you will have an increased risk of these infections, and this kind of prophylaxis can even continue in your patients even up to 3 years, 4 years, even 6 years, depending on your microbiological pattern in your particular city, in your particular setup. So in case you have a patient who's going to be allergic to trimethoprim sulfamethoxazole, then you would want to use other drugs too. So these could be a combination of ativaquonone, but primarily these are not used for prophylaxis, these are used for treatment strategies, and you can combine it with levofloxacin, or you can use pentamidine, you can use dapsone, but these drugs are only for treatment purposes, and very rarely they're used for prophylaxis purposes. In terms of viral prophylaxis, the key strategies are basically the prevention of viral infections, and you have the most important viral infection, which is the CMV. So there are two kinds of protocols. Either you can have a universal prophylaxis in which you will give your drug to all the patients irrespective of their status, or preemptive therapy, which turns out to be a little more financial burden on your patient because you will be testing the CMV viral load again and again, and then adding the drug once you find that the CMV is positive. So the drug that is used for that uniformly all over the world is oral valganciclovir. And we are blessed in this country that the cost of oral valganciclovir is very cheap, so we can use it very effectively even in the government setup. So the recommended dose is 900 milligrams twice a day, but in our setup we are using it at 900 milligram daily. And we reduce the dose further if you have a patient who does not have very good graft function in the initial period. Most of the guidelines would recommend a 100-day prophylaxis for intermediate risk patients and a 200-day prophylaxis for high risk patients. We'll discuss about the low risk and the high risk patients. There is another drug called as letermovir, which is also used, but unfortunately it does not cover your HSV. So you can use acyclovir in case you have a patient who already has been exposed to HSV in the pre-transplant era. So in terms of fungal prophylaxis, as the time from the kidney transplantation increases, your patients are more predisposed to getting more fungal infections because the load of immunosuppression is increasing day by day as you keep on loading them with immunosuppressant medicines. And the risk is with the organisms such as Candida, and it can be replaced by endemic mycosis such as histoplasma, blastomycosis, and coccidiomycosis. These are commonly seen in our practice, especially when patients are coming to you from the rural setup. And histoplasmosis appears to be the most frequent endemic mycosis in solid organ transplantation patient, occurs in up to 0.3% of your patients, and generally occurs within the first 5 years, that is 2 to 5 years post-transplant. And it presents either as a disseminated disease or just as a localized disease, just such as pneumonia. The treatment obviously here would be to use amphotericin B. Depending on the body weight, you will dose the patient, and depending on the clinical response. So there appears to be multiple publications on how much drug to be used, how much period to be used, and there seems to be no uniformity. So you have to use it as you desire to, and then replace it with an azole therapy, and prophylaxis is generally not recommended against histoplasma. So blastomycosis is also rare, but it can occur up to 2 years post-transplantation, and it presents most often with pneumonia and sometimes with disseminated disease with cutaneous lesions. So severe cases of blastomycosis will require amphotericin B followed by azoles, but if you have a mild case of blastomycosis, you can just about treat them with azoles. Coming to the second part of my talk, which is to deal with vaccinations, and which is very fascinating, is because KDIGO recognized that vaccinations is a very important point, and so they had a guideline in which they put in vaccinations as an important point of post-transplant care of your patients. So the vaccination is compulsory. And so the ATS also recommends vaccination against most of the infections that we deal with in our country, such as influenza, diphtheria, tetanus, pertussis, streptococcus pneumonia, hepatitis B virus pre-transplant, and in addition to other age-appropriate vaccination in all potential kidney transplant candidates. So the general rule is to receive all age-appropriate inactivated vaccines. The word is inactivated vaccines as per general population guidelines. So in case of hepatitis B, the vaccination should be guided by the anti-HBs titers. You should check at least 3 months post vaccination, and then annually, and this goes so even after the transplantation period. Live vaccines are generally contraindicated in post-transplant, and if you have to give them, then you have to wait for at least 4 weeks after the you have to wait for at least 4 weeks before you do the surgery. So timing of post-transplant is ideally you should defer the vaccines for 3 to 6 months, which is actually the most intense immunosuppression phase, except in patients who have high risk for influenza. So you can give inactivated influenza vaccine, and that can be given even as early as 1 month post-transplant. And if you have these patients in the flu season, then you can use this vaccine. Additional vaccines, such as certain inactivated vaccines, can be given based on the individual risk factors, but these should be relevant to your transplant population. Coming down to this busy slide, in which just wanted to show you that look at the number of vaccines that can be given to your patients who are in the transplantation, pre-transplant and post-transplant. But you will see very clearly over here that most of the schedules that have been approved by different societies and different guidelines are almost the same as general population in the pre-transplant period. So in the pre-transplant period, you have streptococcus, hepatitis B, hepatitis A. There was a talk about SARS-CoV-2, which we don't do routinely now. The human papilloma virus, MMR, the polio, rabies can also be given at least 4 weeks prior to kidney transplantation. So there are some vaccines which are given 2 weeks prior. There are some which are given 4 weeks prior. If you look at the earlier the vaccines such as the influenza or the streptococcus pneumoniae or the herpes zoster can be given at least 2 weeks prior to kidney transplantation. But when you come and transplant these patients, when are you going to give these vaccines later on? Is at least 6 months, though it is 3 to 6 months, but we should wait for at least 6 months because that's the time in which immune reconstitution takes place, and it's the most effective to give these vaccines during that period. So when we narrow it down to just kidney transplant recipients, that was the slide which I showed for patients who were pre-transplant as well as post-transplant. When you narrow it down to about kidney transplantation patients, you will see that there are 2 kinds of vaccines over here which are an absolute no, because they're live attenuated vaccines. One is the influenza live attenuated, unless it's absolutely compulsory, you would not want to give to your patients. And the smallpox vaccine, these should be avoided in patients post kidney transplantation. So in terms of hepatitis B vaccine, it should ideally be given before ESRD, but many patients will remain unvaccinated pre-transplant, and that is state of affairs that we have, because most of our patients crash land to us for dialysis, and we don't have any other option but to start them on dialysis, and then we lose them to vaccinating them before they can go into a transplant or a preemptive transplant or a transplant, a prospective transplant later on. So the post-transplant recipients with an anti-HBs of less than 10 should be vaccinated, and you should preferably do this after, you should also check the titers 3 months after the transplantation is done. The response rate varies from patient to patient, but it can go as high as about 90% and as low as about 20%, and the antibody levels will decline quickly. So that's why the anti-HBs titers should be monitored every 6 to 12 months, and a booster dose should be given in the post-transplantation period when the levels fall below 10 international units per ml. However, the response to these boosters are also limited in your transplantation patients. For pneumococcal vaccine, both the 13-valent conjugate vaccine, which is the PCV13, and the 23-valent polysaccharide vaccine, which is a PPSV23, are safe and they're recommended. And this is what we are doing in most of our patients. We are following the same schedule as that for the general population. So in your immunocompromised adults, as per the guidelines, the PCV13 is to be given first, and then after 8 weeks, you have to give PPSV23. Now, if the PPSV was given earlier, then the PCV13 should be administered at least 1 year later, and you can repeat the PPSV23 if required, and you can space it up and repeat it after about 5 years. So since the 2014, we have guidelines from the American College of Immunization, which recommends that both of these vaccines should be given to all your patients, even if they're in the CKD population, more than 65 years of age, and who are even high risk, more than 19 years, and who are immunocompromised. Just 3 slides more, if I may be permitted. Thank you. So coming down to the last 2 or 3 slides, one is, this is a very, there's an upcoming vaccine that has been introduced in our country about 1.5 years back, which is the Shingrix, and it provides prophylaxis against shingles. It's been recommended by the CDC for prevention of shingles in immunocompromised adults 19 years of age or older, and 2 doses have to be given. You can space it up to 6 months from the first dose, and it is 9 times more common. Shingles is 9 times more common in immunocompromised patients compared to those who are immunocompetent. So I think it's an important vaccine that can be included in your list of vaccinations. For influenza vaccine, I think we've already discussed. HPV vaccine is ideally completed before kidney transplantation. But however, if you have already started in the pre-transplant, but you have not been able to complete the vaccination totally, the additional dose may be given at least 3 months post-transplantation when the immunosuppression intensity decreases. The seroconversion rate is up to 70%, and the unvaccinated recipient should receive the vaccine if they meet the eligibility criteria. So you have young girls, you have boys of similar age, and somebody who's trying to catch up with his vaccination. The role of HPV vaccination in both male and female kidney transplant recipients is expected to expand in the future, and we still don't know. This is a big, huge slide, and we've discussed most of it, so I will just skip it, but just wanted to tell you what are contraindicated. The MMR, the influenza live, the varicella live vaccine, the rabies vaccine can be given very easily, so there is no problem in the post-transplant period, because we do have patients who come to us with dog bites post-transplantation. So to summarize, ladies and gentlemen, we understand from the talk that prophylaxis is essential, and the single most important drug appears to be a combination of sulfamethoxazole, cotrimoxazole, which is for pneumocystis jirovecii, and antivirals, antifungals should be used in high-risk population. You have to select and see what's the endemicity of TB in your subpopulation and maybe give them prophylaxis for at least 6 months. You should vaccinate preferably pre-transplant. Live vaccines only before, and inactivated vaccines are safe, but they're safe after, but they're less effective. The core vaccines post-transplant are influenza annual, the pneumococcal vaccine, hepatitis B, and HPV. The timing matters a lot, because if you delay most of the vaccination, you have to delay it more than 6 months post-transplant when the immunosuppressant intensity is reduced. And there has to be an individualized, tailored immunoprophylaxis vaccination schedule depending on your local epidemiology, on the serostatus, and what is the patient risk factor. Thank you very much. And I end my talk with this important monument here, which is called Chittorgarh. And I think if anybody has time, they should go and see this also, because there's the history of Johar, which is a very interesting concept, which was brought about by ladies in Rajasthan. And I think you should see it. Thank you very much for your patient listening.